This conference will now be recorded.
Store of it. ఓకే ఇదే కదా నెంబరు 2004 ఓకే జస్ట్ ప్రాబ్లమ్ తో జస్ట్ గుడ్ మార్నింగ్ ఎవ్రీబడి సో in continuation of the last class so today so mainly I'm going to discuss about the adrenal function test. So let us see very briefly adrenal gland. So as all of you know that the adrenal gland is located above the kidney, and it is made up of the outer capsule, outer cortex, and inner medulla. And adrenal cortical hormones are different, and adrenal medullary hormones are different. Okay, so now, so the outer cortex again divided into zona glomerulosa, zona fasciculata, and zona reticularis. So the zona glomerulosa zona glomerulosa secretes melanocorticoids. Zona fasciculata secretes synthesize and secretes the glucocorticoids, and zona reticularis secretes and synthesis the androgens, estrogen, testosterone, and inner medulla synthesize epinephrine, non-epinephrine, and peptides like somatostatin substance P. So the example for melanocorticoids, because the name itself indicates melanocorticoids, aldosterone, and corticosteroids mainly involved in the electrolyte balance. Okay, and the next glucocorticoids. The name itself indicates the cortisol and cortisone are examples. So the name itself indicates the glucocorticoids. It shows its impact on carbohydrate metabolism. So anyway, androgens. So estrogen, testosterone, these two are the sex hormones. So catecholamines, epinephrine, non-epinephrine. So the zona glomerulosa, the hormones which are released from the zona glomerulosa are melanocorticoids, mainly aldosterone. So it increases urinary excretion of the sodium, the potassium, and reabsorption of sodium and retention of water. This is the main role played by the melanocorticoid. Then coming to the zona fasciculata secretes the hormone which is released from zona fasciculata is cortisol. There is example glucocorticoid example. So for glucocorticoids, it's mainly cortisol. So it increases the blood sugar level. How it increases the blood sugar level? So by gluconeogenesis and retention of water, and it acts as an anti-inflammatory effect. Next, zona reticularis. Anyway, it releases the androgens, sex hormones. So all these hormones, because you know that the hypothalamus, some tropic hormones are released in hypothalamus, which acts on the pituitary gland. So again, pituitary gland is divided into anterior pituitary and posterior pituitary. So then we are talking about the adrenal gland. So corticotrophic releasing hormone, this is a tropic hormone which is released from the hypothalamus, acts on the uh, anterior pituitary. Anterior pituitary hormone releases adrenocorticotrophic hormone. So this adrenocorticotrophic hormone acts on the adrenal cortex, and it facilitates the release of the adrenal cortical hormone. So there are, so now For release of this hormone synthesis or release of the hormone from target organ. So the root cause is lies in the hypothalamus. So hypothalamus releases the releasing hormone, that is corticotropin releasing hormone. Corticotropin releasing hormone acts on the anterior pituitary. Anterior pituitary releases adrenocorticotropic hormone. So this adrenocorticotropic hormone acts on the adrenal cortex and facilitates release of the adrenal cortical hormones. So let us see very briefly cortisol. So cortisol, so when you are under stress, this is a stress hormone. When you are under stress, your body responds by releasing a hormone. Okay. So this cortisol is a steroid hormone. It is released from the adrenal cortex and it regulates the carbohydrate metabolism, and at the same time it has an anti-inflammatory effect on the body. So this is structure of the cortisol. It contains the 21 carbon, and the parent compound for synthesis of the cortisol is the cholesterol is the parent. See this one. Cholesterol is the parent. So now see this one. From the cholesterol, the basis of the aldosterone, cortisol, estradiol, all these are takes place from the cholesterol. Okay. So this so now let's see this one. This adrenocorticotropic hormone released from the adrenocorticotropic hormone released from the anterior pituitary stimulates the adrenal cortex, and this adrenal cortex produces the aldosterone, progesterone, and estrogen. And this release of this cortisol is varies. From morning 8 o'clock to 12 o'clock, you can see the peak level. Morning 8 a.m. to p.m. That's why while collecting the blood from the cortisol, it's always advised to collect the sample, early morning sample, especially for cortisol. Early morning test is always preferable because it reaches the peak stage during the 6 to 8 a.m. to the 12 p.m. and see the circadian rhythm. So night times very low. Okay, night times are very low, and from see this on 6 p.m. to the 6 a.m. So 6 p.m. to 6 p.m. evening 6 p.m. to the next day morning 6 a.m. So midnight slowly starts rising from midnight 12 o'clock onwards. Slowly starts at around 8 o'clock it reaches the maximum. So after 12 o'clock, it slowly slows to again 6 o'clock it reaches the 6 o'clock evening it reaches the normal level. So you can appreciate the peak level of cortisol morning between 8 to 12 p.m. So whenever this cortisol, see this one, hypothalamus releases the corticotropic releasing hormone. So this corticotropic releasing hormone under the stress and diurnal rhythm. That's why I said diurnal rhythm. So morning 8 a.m. to the 12 p.m. the levels are very high because so during that time the hypothalamus releases corticotropic releasing hormone. This corticotropic releasing hormone acts on anterior pituitary. Anterior pituitary releases the adrenocorticotropic hormone. Adrenocorticotropic hormone acts on the adrenal cortex and it facilitates release of the cortisol. So the once the cortisol reaches the maximum, this cortisol will go and inhibit the hypothalamus. So this target organ mainly this adrenal cortical hormone increase the blood sugar level, amino acid, and the fatty acids. Okay, these all things are I covered. That's why I'm not going in detail. So this main important role of the cortisol. So that's why the long-term intake of cortisol, steroid injections are not at all advisable. The reason is very simple. The cortisol suppresses the immune system and increases the blood sugar level and heightened memory and attention and increase in blood pressure and decrease the serotonin and sensitivity to the pain also decreases. Since the main beneficial effect is the sensitivity to the pain is decreases, but rest of all are sugar, it increases sugar levels and suppresses immune system and blood pressure levels are increases and heightened memory and attention. So all these covered, almost all the cortisol functions are covered. Let's see the very briefly the effect of cortisol to the body. So the overall effect of the cortisol, arthritis. Okay, excessive effect of excess. If you take more cortisol, because this cortisol is known as stress hormone, if you take the more cortisol, it leads to the arthritis, hunger, posterity, acid reflux diseases, tunnel vision, migraine, sleep deprivation, chronic fatigue, hypertension, depression, and decrease in metabolism, decrease immune system. So that's why long-term intake of cortisol is not at all advisable. See, if you see the functions of the cortisol mainly on protein metabolism. So mainly it inhibits amino acid uptake and catabolism in muscle and skin bone, and excessive cortisol it leads to the severe muscle wasting, and especially the role of cortisol on carbohydrate metabolism. It increases the blood sugar level and decreases the tissue uptake of glucose, and decreases the conversion of glucose to the glucose 6 phosphate, and increase the gluconeogenesis in the liver. And excessive cortisol is a diabetogenic. Excessive cortisol is a diabetogenic. Then coming to the fat metabolism. So on fat metabolism, cortisol, excessive intake of the cortisol is a lipolytic ketogenic. Lipolytic means the mobilization of fat takes place, and excess intake of cortisol leads to the ketosis. Then coming to the role of cortisol on cardiovascular function. So the increase in myocardial contractility and vasoconstriction and myocardial contractility. So this is the role of cortisol. Then coming to the, as already said, it's a anti-stress. Okay, in severe physical or mental stress, cortisol plasma concentration level very high level, extreme in physical or mental stress. So the level goes up to 10 times than the normal, and it's anti-allergic. So it inhibits the allergic responses, it decreases the histamine synthesis and decreases the kinin synthesis. And especially the cortisol is anti-inflammatory. Cortisol inhibits all stages of inflammatory process. It has a stabilizing action on the lysosomal membrane of leukocytes, decrease inflammatory chemical mediator as the prostaglandin interleukins. It suppresses the migration of neutrophils. It inhibits the proliferation of fibroblasts in wound repair. So it's an anti-inflammatory. Okay, so this cortisol suppresses the immune system. Okay, so how it improves the suppresses the immune system? Because it decreases the circulating lymphocytes, basophils and eosinophils, and decreases the antibody production. And the intake of this cortisol, it causes the spread of infection. And only one advantage is it is used in the treatment of autoimmune disease. There are a lot of side effects are there. The cortisol side effects are there, but anyway, so the cortisol is immune suppressive, and the excess intake of the cortisol it causes the peptic ulcers. Okay, so it increases gastric acidity, so that's it causes the peptic ulcers, and excessive cortisol, so it causes the retention of water and sodium, and increases the potassium excretion, and especially cortisol, excessive intake of the cortisol causes the psychosis. So these are the overall, just all of you go through the effect of the excessive intake of the cortisol. I already explained it causes arthritis, hunger, posterity, acid reflux, tunnel vision, migraine, sleep deprivation, all these things it causes the excessive intake of the cortisol is not at all advisable. Then we are moving to the another hormone, that is the aldosterone. So aldosterone, main important. So the aldosterone main role is it acts on the mineral metabolism. So it causes the conservation of sodium ions and secretion of potassium ions. It conserves the sodium, and at the same time helps in the release of the potassium ions and increase the water retention and increase the blood pressure, because overall water is absorbed, that's why blood pressure also increase. So overall effect of aldosterone is to increase reabsorption ions and water in the body. So the aldosterone functions, as I already said, it increases reabsorption of sodium from the distal renal tubules, increase excretion of potassium from the distal renal tubules, increase excretion of hydrogen ions from distal renal tubules, and increase the water reabsorption along with sodium, and decrease the sodium content of set saliva and other secretions, and it acts as a long-term regulator of blood pressure. It acts as a long-term regulator of blood pressure. And let's see the disorders of the adrenal cortex. So the disorders of adrenal cortex. So as all of you aware that there are two kinds of disorders anyway. Sorry, there are two different types of. You can see in general you can see the two kinds of disorders: hypofunctioning, hyperfunctioning. So patients with adrenal disorders can be represented with features related to the hypofunctioning of the gland, hyperfunctioning of the gland. So hyperfunctioning causes the Cushing syndrome, and hypofunctioning causes the Addison's disease. Hyperfunctioning causes the Cushing's syndrome. Let's see the Cushing syndrome. Cushing syndrome. So now, can you make out the difference between normal person and Cushing syndrome person? Okay. So again, Cushing syndromes are two types. So adrenocorticotropic hormone dependent Cushing syndrome and adrenocorticotropic independent Cushing syndrome. So adrenocorticotropic dependent Cushing syndrome means so pituitary adenoma, there's some defect in the pituitary gland, and ectopic adrenocorticotropic producing tumors. So bronchial carcinoma. So here ACTH independent one. So here tumor of the adrenal tumor and adrenal gland tumor and the example adrenal adenoma or carcinoma. Next, coming to the therapeutic corticosteroid administration, these two are the adrenocorticotropic independent. So there are two types of Cushing syndromes. One is adrenocorticotropic dependent and adrenocorticotropic independent. See, these are the consequences of the Cushing syndrome. So starting from head to the toe, so hyperglycemia, CNS irritability, and sodium potassium retention, thin extremities, and GI tract disorder, distress, increased acid productions, and in the females you can see the amenorrhea and hirsutism, thin skin, purple striations, bruises and petechiae, and osteoporosis, and fat deposition and back. In males you can see the gynecomastia and increased susceptibility to infections and moon phase and personality changes. These are the signs and symptoms of the Cushing's syndrome. And let's see the disorders of adrenal cortex. So adrenal hypofunction. So hypofunctioning of adrenal gland leads to the Addison's disease. Hypofunctioning of adrenal gland leads to the Addison's disease. So Addison's disease here. So hypofunction of adrenal gland. Okay, so here the progressive destruction of entire adrenal cortex. So mainly these are all mainly due to the autoimmune based disease, and most likely the result of cytotoxic T lymphocytes, and the 50% of patients have circulating antibodies in them. So we can make out this Addison's disease because you can see this 50% of patients have circulating adrenal antibodies. And what are the causes for the Addison's disease? So failure of cortex to secrete corticosteroids. Okay, so failure of the cortex because hypofunctioning of the adrenal gland leads to Addison's disease. So one is the atrophy, atrophy of the cortex due to the autoimmune diseases, and destruction of the gland during the TB, and destruction of the organ cells in the cortex by malignant tissue, congenital failure to secrete by birth. So if there is any defect in the secretion of cortisol and the failure of the anterior pituitary, because you know that the hypothalamus, anterior pituitary both coordinate for the release of the adrenal hormones. So if there is any failure in the adrenal pituitary, anterior pituitary gland, if there is any lesions in the area of hypothalamus, where the corticotropic releasing hormone synthesis takes place, and these are the reasons for the Addison's disease. So the failure of anterior pituitary and lesions in area of hypothalamus. So these are reasons for this. These are the causes for this Addison's disease. So if we go through ones. So failure of a cortex to release the corticosteroids. Okay. So one is atrophy of the cortex due to the autoimmune disease and destruction of the gland during the TB and destruction of hormone secreting cells in a cortex by malignant tissue and congenital failure to secrete cortisol, and failure of anterior pituitary, because you know that the pituitary gland releases the adrenocorticotrophic hormone. This adrenocorticotrophic hormone acts on the adrenal gland to release the adrenal hormones. That's why if there is any failure in the anterior pituitary, leads to the Addison's disease, and lesions in the area of hypothalamus. This is also responsible for the Addison's disease. Okay, so let us see the common features of the Addison's disease. See this one: bronze pigmentation of skin, changes in the body distribution of hair, and GI distributions, weakness, weight loss, and postural hypotension, hypoglycemia, and these are the adrenal crisis. In adrenal crisis, serum sodium levels are low and potassium levels are very high, and profound fatigue and dehydration, vascular collapse. Okay, so renal shutdown completely takes place. Renal shutdown takes place, and potassium levels are increases, and serum sodium levels are decreases. Okay, so these are the tiredness, generalized weakness, lethargy, anorexia, nausea, vomitings, hyponatremia, hyperkalemia, hypercalcemia, conversions, dizziness and postural hypotension, and pigmentation, loss of body hair in women. So you can see very less common. You can see hypoglycemia and depression. Okay, mainly there is imbalance in the sodium and potassium. That's why we can see the nausea, vomitings, hyponatremia. And hyponatremia means decreased sodium level. Hyperkalemia means increased potassium levels. Hypercalcemia, increased calcium levels. All these things you can see in the Addison's disease. So hyperpigmentation. You can see this. You can easily appreciate the hyperpigmentation of the skin. See this hyperpigmentation of the skin. Okay, so how do you now we are talking about the adrenal function test, because as all of you know that the glucocorticoids are mainly involved in the regulation of carbohydrate, lipid and protein metabolism, and the mineralocorticoids, especially aldosterone, are concerned with the regulation of extracellular fluid volume and electrolyte metabolism. So that's why how to establish the hypo or hyper functioning of adrenal gland. So there are different tests or functional tests are involved to assess the glucocorticoid function or glucocorticoid functions, and especially these all comes under the adrenal function test. So here the estimation of plasma cortisol concentration and synaptin test or adrenocorticotropic hormone stimulation test, and measurement of plasma adrenocorticotropic hormone, METYRAPONE test, and the corticotropic hormone stimulation test, and the plasma renin and aldosterone levels. These are all different investigations. Systematic wise, the investigations are performed to come to the conclusion whether the person is suffering with hypo or hyper functioning of this gland. So now, so first let us see the first test under the adrenal function test. The first test is the assessment of the diurnal rhythm. So assessment of the circadian rhythm in cortisol secretion, because as all of you aware that the release of the cortisol is varies. So evening 6 p.m. to the morning 6 p.m., morning 6 a.m. So previous day evening to the previous day evening to the next day morning 6 p.m. Previous day 6 p.m. to the next day morning 6 a.m. You can appreciate a very low level of this cortisol, and the cortisol levels are slowly rises and reaches the maximum. You can see between 8 to 12 p.m. So that's why the intake of the morning sample is always advisable for the cortisol estimation, and measurement to measure between 8 a.m. to 11 p.m. the cortisol level is the very good. Is advisable time for this cortisol test. So this test is commonly estimated by radium-minase, RIA, and this you can see. That's what I said. So here normal level you can see in between. Serum normally you can see between high level you can see between 8 a.m. to 12 p.m. and serum value midnight is 50% less than the value at the 8 a.m. So in Cushing syndrome, you can see this rhythm. Always high level only you can see in Cushing syndrome. That's why this rhythm is lost. This rhythm is lost. And in pseudo Cushing syndrome, you can appreciate the normal circadian rhythm, but in Cushing syndrome, this rhythm is lost. Then measurement of 24 urinary free cortisol. So this is another useful screening test in the estimation of the 24 urinary cortisol. The free cortisol in 24 hours urine sample. The test should be performed on three different collection samples: normal daily excretion. See this one. So, so here the measurement of 24 hours urinary free cortisol level. So if the 24 free cortisol level less than 300 micromoles in 24 hours, it's a normal. 300 to 700, it indicates the severe depression stress. And if the level is processed more than 700 micromoles for in 24 hours urine, if it crosses beyond 700 micromoles, so it indicates the patient is suffering with Cushing syndrome. So that's why the first criteria is the estimation of the free cortisol in blood as well as the urine and in blood sample also. So we have to collect the blood sample between 8 a.m. to the 8 a.m. to the 11 a.m. That is advisable time. So during that time you can see the peak, and at the same time normal times you can midnight times you can see the very low, very low level of cortisol you can appreciate during the night time. So that's why the measurement of first adrenal function test is the measurement of the free cortisol in the urine as well as in the blood. That is advisable. And then coming to the next, we start with the suppression test. So to find out where is the exact reason. So this is a dextromethasone suppression test. So this test is a synthetic glucocorticoid. Dextromethasone is it's a synthetic glucocorticoid, and this synthetic glucocorticoids here this about 2 milligrams of oral caps. This is one kind of synthetic glucocorticoid. Dextromethasone is a so this is a capsule. This is given peroral administration. The oral administration of this glucocorticoids. This inhibits the inhibits this adrenocorticotropic hormone production via the native feedback inhibition. So here, so this low dose of dextromethasone suppression test here, 0.5 milligrams of dextromethasone is given orally. It's available in the form of, as already said, it's a synthetic glucocorticoid. It is a synthetic glucocorticoid. It is available in the form of tablet, and this tablet is given 6 hours for 2 days. Every 6 hours for 2 days, and blood for plasma cortisol is collected 6 hours after the last dose, and urine for urine free cortisol is collected before and on the second day of the test, and first day and second day. So here this dextromethasone is given every 6 hours for 2 days, and very low dose of dextromethasone is given. So because it suppresses the release of the adrenocorticotropic hormone. That's why you can find the in normal persons. So because of inhibition takes place, because of the inhibition, you can see the urinary free cortisol levels you can suppress by 50%. 50% can suppress. That's why you can see in normal persons, we can see the less than 7 nanomoles for 24 hours urine sample. You can see the less than 74. And in pseudo Cushing's, you can see the less than 140 nanomoles per liter, and in Cushing syndrome, no suppression. So it's still that levels are maintained. So whatever low dose we are meeting, low dose of dextromethasone we are giving, that is not able to suppress the adrenocorticotropic hormone to release the adrenal cortical hormone. That's a no suppression. So that's why the plasma cortisol level and urinary free cortisol levels are it maintains no suppression and the levels are very high in case of Cushing syndrome. And next is if you are not satisfied with this low dose, then high dose of dexamethasone is feasible. Normal individuals and suppression of this cortisol to the less than 50 nanomoles per liter takes place, and patients with Cushing syndrome fail to show the complete suppression of plasma cortisol level. This test is highly sensitive 90. And even high dose also, you can first you have to try with low dose, and if you like low dose also still is in Cushing syndrome, still the levels are maintained, and then after giving the high dose dexamethasone methasone and high dose of dexamethasone separate test also, and this Cushing syndrome person still it shows the it still does not fail to show the complete suppression of this plasma cortisol level, and this is 97% accuracy is there this test. Then so once first test is the estimation of cortisol in urine and in blood. So second one is the low dose of dexamethasone suppression test, and next one is the measurement of the plasma adrenocorticotropic hormone. So elevation of the estimation of the plasma adrenocorticotropic hormone. That is the next test. In the phase-wise manner, we have to rule out the cause. Okay, first test is the estimation of cortisol in serum and in plasma. Second one is the suppression of the suppression of the release of the corticotropic hormones from the adrenal gland by using the dexamethasone is a suppressor. And next coming to the next one is the measurement of the plasma adrenocorticotropic hormone level. So ACTH level, plasma adrenocorticotropic hormone, because you know that the this plasma adrenocorticotropic hormone levels are adrenocorticotropic hormone released from the anterior pituitary gland. In normal level, normally you can see the less than 50 nanograms per liter, and in adrenal causes, and you can see the very low level, and in slightly elevated levels, you can see the pituitary dependent Cushing syndrome, and the gross elevation of the adrenocorticotropic hormone leads to the ectopic secretion of the adrenocorticotropic hormone. So here in this mainly the significance of this test is the so cortisol and adrenocorticotropic hormone interacts in a feedback loop. Low level of serum cortisol associated with the low level of the serum cortisol associated with the high plasma adrenocortical level would indicate the primary adrenocorticotropic insufficiency, and likewise increase in plasma cortisol will be associated with suppression. Sometimes cortisol, if the cortisol levels are low, and suppression of the adrenocorticotropic hormone in primary adrenal lesions takes place. So that's why by estimating the ACTH hormone, you'll come to know that the slight elevation pituitary dependent Cushing syndrome, and the gross elevation you can see the ectopic secretion of the adrenocorticotropic hormone. So next test is the adrenocorticotropic hormone stimulation test. So this because you know that the so whenever this adrenocorticotropic levels are very high, so by negative feedback inhibition it inhibits the cortisol level, and low adrenocorticotropic level anyway you come to know that the so low cortisol. So that's why in primary adrenal insufficiency, so the defect, so by measuring this by performing this adrenocorticotropic hormone simulation test, if the defect to find out the exact reason, you will find out exact location where this defect. So here the primary adrenal insufficiency, you will see the very low level of cortisol, and plasma adrenocorticotropic hormones are very high. And in secondary and tertiary adrenal insufficiency, you can see in both conditions, serum cortisol as well as the plasma adrenocorticotropic hormone levels are both are very low in the secondary and tertiary adrenal insufficiency. See this one. So this Hypothalamus releases corticotropin hormone, corticotropin releasing hormone acts on the anterior pituitary. Anterior pituitary releases adrenocorticotropic hormone. Adrenocorticotropic acts on the adrenal cortex, and this adrenal cortex facilitates release of the cortisol. So this cortisol will go and inhibit the, if the levels are very more, this cortisol will go and inhibit the hypothalamus. Okay. So here, the adrenocortical stimulation test are it is known as synaptin test. Pills. So takes blood size here. Two tests are there, and short test and long test is there. In short test, take blood sample at 9 a.m. morning for measurement of cortisol. After that, use intravenously or intramuscularly inject the 250 micrograms of adrenocorticotropic hormone, and you take these further blood samples of 30 minutes and 60 minutes. You measure the cortisol levels. So here the adrenocorticotropic hormone stimulation test are cyanthin test. So another name for this adrenocorticotropic hormone stimulation test is cyanthin test. So here there are two types of tests are there, and short test and long test. In short test, so first we'll take the blood sample at around 8 a.m. 8 a.m. we'll collect this blood sample. After that we'll inject the 250 micrograms of adrenocorticotropic hormone intramuscularly or intravascularly, and you take the next after 30 minutes and after 60 minutes, and again we'll collect the blood sample and we'll measure the cortisol. This is the short-term test. And here long-term test here. So we'll inject the 1 milligram adrenocorticotropic hormone intramuscularly, and second day, third day we inject the same amount, and fourth day also fourth day again we will perform the same 250 micrograms. We again will perform the short test on third day. Fourth day we'll perform the short test and we will measure the cortisol level. So this adrenocorticotropic stimulation hormone. So here, successfully we'll measure the chronic adrenal insufficiency, whether the adrenal gland is reacting to the adrenocorticotropic hormone or not. We are stimulating the adrenocorticotropic hormone by injecting the cyanthin, cyanthin test, and here we'll assess the chronic adrenal insufficiency. We can assess. Then coming to the next test is the METYRAPONE METYRAPONE blood test. Here we'll measure the ability of the pituitary gland to release the adrenocorticotropic. So the main target is here the pituitary gland, whether the pituitary gland is responding, or pituitary gland, the ability of the pituitary gland to release the adrenocorticotropic hormone in response to decrease the blood cortisol. So whenever this blood cortisol levels are decreases, so whenever this blood cortisol levels are decreases, and adrenocorticotropic hormone will go on will go release from the adrenal gland, anterior pituitary gland. It acts on the adrenal gland to facilitate release of the cortisol. So whenever this cortisol levels are very high, this cortisol itself will go and inhibit the adrenocorticotropic hormone. That's why here the METYRAPONE test here, METYRAPONE test, METYRAPONE stimulation test here mainly will this will go and inhibit the cortisol production. This will go and inhibit the cortisol production. See this here. The key enzyme here is the 7-alpha hydroxylase. So this is the key enzyme for the production of the cortisol. So this because you, as all of you aware, the cholesterol is the parent for synthesis of the cortisol. So here in a METYRAPONE test, this METYRAPONE will go and inhibit this 17-alpha hydroxylase enzyme. So by inhibiting this enzyme, the cortisol formation does not occur. So that's why instead of this cortisol, this cholesterol is diverted for the synthesis of the progesterone. So is diverted for synthesis of the progesterone. This test is used to decline delineate the cause of Cushing syndrome. So metropone is a potent inhibitor of the 11-alpha hydroxylase enzyme. Therefore, oral administration of the metropone blocks the cortisol synthesis. So this mainly blocks the cortisol synthesis, and this removes the negative feedback effect on pituitary. The excess of adrenocorticotropic hormone secretion continues to drive steroid biosynthesis, but with the pathway of cortisol synthesis blocked, the initial formed precursor, that is the progesterone, the initially formed precursor progesterone, stops at 11-deoxycortisol. So therefore, the serum level of progesterone and these initial precursors rise, followed by the metropone administration. Likewise, we see here what happens is urinary excretion of the 17-hydroxy cortisol, 17-hydroxy 17-hydroxy corticosteroids also increases. So here, you know, in Cushing syndrome, caused by a pituitary tumor, the adrenocorticotropic hormone response remains intact, and 11-dehydroxycortisol level shows marked increase, and levels of the 11-deoxycortisol that are less than these are consistent with the adrenal tumor or ectopic adrenocorticotropic hormone. So next, coming to the next one is the last test is the corticotropic hormone, corticotropic releasing hormone stimulation test. So this mainly differentiates between the secondary adrenal insufficiency, pituitary or hypothalamic, hypothalamic. So they just should it is the differentiate between the pituitary cause of Cushing syndrome from other causes, because you know that the pituitary cause here. So to find out the reason where the problem lies, so whether it's in pituitary gland or in the any other causes, this test is used, and this test is now considered definitive in the differentiation of the pituitary cause of Cushing syndrome from the other causes, because you are aware that the Cushing syndrome is not only due to the pituitary gland, some other adrenocorticotropic dependent, adrenocorticotropic independent, two different types of tests, two different types of reasons are there in Cushing syndrome. So here in the corticotropic releasing stimulation test, this test is now considered differentiate in the differentiation of pituitary cause of Cushing syndrome from other causes. If there is no adrenocorticotropic hormone response after a corticotropic releasing hormone stimulation test, the disease is of pituitary origin. So after giving this corticotropic releasing hormone, if you see the blunted or nil response, the problem lies in the pituitary. And if you see the positive response, the lesion is in hypothalamic region. That's it. To differentiate the reason for the Cushing syndrome, if the pituitary origin or not, this is the best test. That's the corticotropic releasing hormone test. Then we'll move on to the last topic, that is the adrenal medullary hormones. So adrenal medulla, it releases the catecholamines and peptides. So catecholamines, example for catecholamines, adrenaline, non-adrenaline, and dopamine, and the peptides, opiate peptides, adrenomedullin, arginine, vasopressin, vasoactive intestinal peptides. So see, this adrenal medulla releases the adrenal hormone as catecholamines as well as the peptides. Example for catecholamines, adrenaline, non-adrenaline, dopamine, and peptides like opiate peptides, adrenomedullin, and arginine, vasopressin, vasoactive intestinal peptides. They are all released from the adrenal medulla. So, this medullary hormones are released by the two types of chromaffin cells. So one type of cell secretes non-epinephrine, and other types of secretes epinephrine. These hormones are mainly stored in the chromaffin granules. In humans, 80% of chromaffin granules contains the epinephrine, and 20% of the granules contains the non-epinephrine. So both together, these epinephrine, non-epinephrine, these are called as the catecholamines. These are called as the catecholamines. So this catecholamines is contains catechol nucleus and amino group. So the source for this catecholamines is the tyrosine is the source for the origin of this disease. and especially in the this is epinephrine, non-epinephrine. So this is known as the stress hormone. So mainly these hormones are released during the fight and the flight hormones. So in different situations, you can see the release of this hormone. Main function of important function of catecholamines, it increases the glycogenolysis and gluconeogenesis and decrease the glycogenesis. And this catecholamines it promotes the release of glucose from liver and decrease circulation by muscle. And epinephrine it inhibits insulin secretion by promote the glucose secretion. Overall, the effect of this catecholamines on carbohydrate metabolism is hyperglycemic hormone and effect on lipid metabolism. So it increases the enhances the breakdown of triglycerides and adipose tissue and increase the free fatty acids in circulation, which effectively these free fatty acids are effectively utilized by the heart and muscle as a fuel. And another important function, physiological function of the this catecholamine, it increases cardiac output and blood pressure and increase oxygen consumption and they cause a smooth muscle relaxation in bronchi, GIT, and blood vessels supplying the circulation. And the excessive, too much release of the it is a hormone. So catecholamines, too much release, so it leads to the pheochromocytoma. Pheochromocytoma, it's a rare tumor of the neuroendocrine system, pheochromocytoma. So here you can see the 5 P's. There is a pain, headache, pallor. Okay. So orthostatic hypotension from impaired arterial and venous constriction response, and palpitation you can see, and hypertension, there is pressure, and perspiration. These are the 5 P's you can see in the pheochromocytoma. So that's the end of the session. Adrenal corticotrophic hormone functions.